Welcome to this explainer. Today, we're unpacking something that is literally life-changing: the structured decision-making processes that medical professionals use to navigate the absolute highest stakes imaginable in maternal and pediatric care. We're going to look at exactly how doctors take what could be sheer chaos and turn it into incredibly precise, life-saving protocols. To understand this, we're going to map out the continuum of care across three crucial stages: birth after cesarean, an umbilical cord prolapse emergency, and finally, managing pediatric sepsis. All right, let's dive into part one: birth after a cesarean, and how we weigh those options. If you're mapping out a birth plan after a previous C-section, the very first term you're going to hear is VBAC. That stands for vaginal birth after cesarean. It's a crucial term that really encompasses the option to attempt a vaginal delivery, which, by the way, also includes assisted births using forceps or a ventouse following a prior C-section. Now, the baseline numbers here might actually surprise you. You might think, well, one C-section automatically dictates another, right? Actually, no. For women with a straightforward pregnancy, a massive 75%, that's 3 out of 4, achieve a successful VBAC. It's a highly encouraging success rate, and medical teams take real pride in offering this trial of vaginal delivery. But making this call isn't just about looking at success rates, is it? It requires weighing the options side by side. On one hand, a successful VBAC offers a way shorter recovery, less abdominal pain, a shorter hospital stay, and you entirely avoid surgery. Plus, it increases the chance of an uncomplicated normal birth in future pregnancies. On the flip side, an elective repeat C-section gives you a known delivery date, avoids the general unpredictability of labor, and carries virtually zero risk of uterine scar rupture. So it really comes down to a deeply personal choice of weighing different types of predictability. But of course, doctors absolutely have to lay out the risks so parents can make a fully informed choice. And the data shows there is a 25% chance of needing an emergency C-section if labor slows down or if there are concerns for the baby's well-being. There's also a 1% risk of a uterine infection or needing a blood transfusion. And then there's about a 0.5% chance, to put that in perspective, that's 2 to 8 women in 1,000, of the previous uterine scar weakening or fully rupturing, which requires an immediate emergency delivery.
And it's important to note that the medical pathway dictates VBAC just isn't advisable for everyone. It's not recommended if the mother has had 2 or more previous C-sections, a classical high uterine incision, or a previous uterine rupture. And here is where nature loves to throw a curveball. If you do choose the elective C-section route, which is usually scheduled 7 days before the due date, keep in mind that 1 in 10 women will go into early labor before that scheduled date anyway. That can dramatically shift the plan right back toward an emergency C-section or even a VBAC, depending on how advanced the labor is.
Moving into our second section, umbilical cord prolapse, in the 30-minute ticking clock. So what happens when all that careful, structured planning instantly transforms into a sudden life-or-death emergency during delivery? Take an umbilical cord prolapse, for example. This is a severe situation identified when an abnormal fetal heart rate pattern begins immediately after the mother's water breaks. When doctors suspect this, the absolute most important first step is an immediate digital vaginal exam. If a prolapse is confirmed, the medical protocol shifts into overdrive with strict, immediate mechanical steps to relieve pressure on that cord. First, they perform the exam. Second, a provider has to manually push the presenting part of the fetus upward. Alternatively, they can fill the mother's bladder with 500 to 750 milliliters of fluid to elevate the baby. And third, the mother is quickly optimized into a specific position, like a knee chest pose or an exaggerated left lateral position with a hip pillow, to further reduce that dangerous compression. And here is where time becomes everything. We're no longer weighing options over weeks. The team is now racing against a strict 30-minute target. The absolute, non-negotiable goal is to deliver the baby via a Category 1 cesarean section within 30 minutes or less. Every single mechanical step taken before this is just about buying precious seconds for the surgical team to assemble. And that brings us to our final section, pediatric sepsis, and navigating the triage tree. Now let's transition from the delivery room to childhood. How do doctors handle another terrifying scenario like suspected pediatric sepsis? Well, it begins with a highly structured assessment matrix. If a child under 16 meets even one single high-risk criterion, it triggers a massive response. A senior decision maker, an ST4 doctor or above, doesn't just watch and wait. They immediately order venous blood tests for gas, glucose, lactate, and cultures. And just like with our delivery emergency, we have a ticking clock.
For these high-risk patients, IV antibiotics have to be administered within a strict 1-hour window. This 60-minute target is quite literally the cornerstone of the sepsis survival protocol.
From there, the flowchart forces a major diagnostic pivot based on those test results. The primary questions are asking, is the lactate level over 4 millimoles per liter? Or, let's say for a 12 to 15-year-old, is the systolic blood pressure under 90?
If the answer is yes to either of those, the protocol instantly flags this as extreme severity. Immediate action is required. The medical team has to give an IV fluid bolus within 1 hour, carry out observations at least every 30 minutes or just monitor continuously, and refer the child directly to critical care.
But what if the numbers are a little lower? The protocol accounts for that too. If the lactate is between 2 and 4, the IV bolus is still strictly given within an hour. If it's less than 2, the fluid bolus is only considered. But here is the brilliant part. Built into every single branch of this pathway is a vital failsafe. In both cases, if there is no response to any intervention within 1 hour, a consultant must be immediately alerted. The system literally never allows a patient to linger without a senior review. So looking at all this, from navigating weeks of thoughtful birth plans, to racing a 30-minute prolapse clock, to flawlessly executing a 1-hour pediatric sepsis protocol, we see a profound truth about modern medicine. How does transforming the sheer chaos and panic of medical emergencies into these rigid, branching, carefully designed pathways ultimately redefine the boundaries of human survival? The next time you see medical professionals working swiftly in a crisis, remember, they aren't just improvising. They're executing an absolute masterclass in structured, life-saving logic. Thank you for joining me for this explainer. Keep learning and keep asking the big questions.